personalized teaching learning experience. And over the last half an hour, I will try to cover the basic concepts of management of lupus nephritis, including what the broad goals of management should be, the intricacies of managing children versus adults, the standard of care therapies, the newer agents and their applicability in children, and the long-term outcomes. Lupus nephritis is an important manifestation of SLE and is almost 2 times as common in childhood as compared to adults. It's observed in 40 to 80% of children and is prevalent in patients with East and Southeast Asian ethnicities. Lupus is diagnosed, classified, and the extent of tissue damage is assessed on a kidney biopsy. Over the years, the ISN-RPS 2003 lupus classification has undergone various changes and has recently been updated. But overall, there are 6 classes of lupus nephritis. Now, it is important to classify lupus nephritis into all of these classes because the management as well as the prognosis would depend on these classes. On immunofluorescence, the classical pattern is a full house nephropathy with deposition of all immunoglobulins and complement components. More than 2/3 of lupus nephritis on a biopsy is usually a severe proliferative class 3 and class 4 lupus nephritis. And patients classically would present with a nephritic syndrome with hypertension or deranged renal functions, with or without other severe organ manifestations of lupus. Class 5 lupus nephritis, which is the membranous lupus, on the other hand, would generally tend to present with a nephrotic range proteinuria, nephrotic syndrome, or edema. Having said that, it is important to recognize that a kidney biopsy is indispensable since in most cases, clinical, serological, or lab tests cannot accurately predict the kidney biopsy findings. And there have been many studies showing that the clinico-histopathological correlation of lupus nephritis is often inaccurate. Sometimes patients with class 3 and class 4 severe proliferative lupus may also present with seemingly benign urinary findings. And so it is important not to miss lupus nephritis in patients with SLE and therefore have a low threshold for renal biopsy. So this is the protocol that is followed in AIMS currently, and the indications for a kidney biopsy would be a proteinuria of 1 plus or more, or a UPUC ratio of 0.2 on an early morning spot urine, or persistent microscopic hematuria, or deranged renal function tests. Another area of considerable variability is the definition of remission and whether it should be similar in adults versus pediatric lupus. The 2021 KDIGO guidelines define complete response as a reduction of proteinuria to less than 500 milligrams per gram and a stabilization or improvement in kidney function. However, pediatric nephrologists generally emphasize a more stringent targets of proteinuria reduction to define complete remission. And the CARA consensus guidelines, which is a pediatric guideline, would define complete remission based on the presence of normal kidney function, proteinuria on an early morning spot UPUC ratio of less than 0.2, or less than 300 milligrams per meter square on a 24 hours protein, and the presence of an inactive urinary sediment. Now, this proteinuria threshold is much lower than the widely accepted norms of 500 milligrams per grams that is widely accepted in adults. There have been studies that show that the risk of flare is significantly higher in patients who show a partial remission when compared to patients with complete remission. And therefore, it is important to target complete response or complete remission wherever feasible. So while it's acknowledged that a prompt fall in proteinuria is associated with a good renal outcome, the right treatment targets in lupus are still unclear. In adults, there's a consensus that a proteinuria reduction to less than 0.5 to 0.7 on an early morning spot protein after 1 year of therapy predicts good long-term renal outcome with a positive predictive value of 94%. The problem is that the negative predictive value of this threshold is extremely low at 31%. Now, this means that 69% of patients who did not achieve the target and continue to have high range of proteinuria will still have good kidney outcome. And so the challenge with this target is that how do we identify these 1/3 of patients who do not achieve this target and will suffer from long-term renal impairment? And also the challenge is, how do we identify these group of patients early enough so that a change or modification in their therapies can be done? So one such strategy is the treat to target strategy, which has been developed, and a consensus in adult literature is emerging about these various targets. There are studies that use a pathological target, that is using an activity indices on sequential renal biopsies to guide treatment. The apparent advantages of this approach are a low flare rate when compared to contemporary metrics, no incidence of ESKD, and a relatively low number of patients needing to be treated to realize this benefit. So data in pediatrics is limited, and in the most latest study in 200 odd patients with a median follow-up of 27 months showed that the authors looked at clinical targets, including varying levels of remission and a low disease activity status. And when the patients were classified accordingly, the authors found that patients entering remission were only 1/3 of the total population, and hardly any patients had a low disease activity status. So the authors concluded that pediatric lupus is probably a more active disease, and more data is required before such treat to target strategies are widely adopted in clinical practice in pediatrics. Overall, the rate of remission in pediatric lupus nephritis at 1 year is about 60%. It does vary across studies, and this is this was from a systematic literature review that used the most stringent pediatric CARA consensus guidelines for defining complete remission. The overall outcomes of pediatric lupus nephritis has improved over the last 3 decades because of the introduction of newer immunosuppressive agents. But pediatric trials are limited, and in adult trials, generally they would include patients with class 3, class 4 proliferative lupus nephritis. And so the evidence of treating patients with class 2 and class 5 lupus nephritis is still low. Class 2 lupus nephritis is generally treated based on the extrarenal manifestations, and it is acknowledged that a severe proteinuria in patients with class 2 nephritis merits treatment with long-term immunosuppression in the form of prednisolone or MMF. Treatment of class 3 or class 4 lupus nephritis is based on randomized controlled trials conducted in adults, and it is conceptually divided into an induction therapy for the initial 3 to 6 months, followed by a maintenance therapy, the duration of which is still unclear and is debated. So the goal of induction is to induce remission by controlling inflammation and minimizing parenchymal injury. And the goal of maintenance is to prevent kidney flares and progression of chronic kidney disease. Induction includes pulses of IV methylprednisolone at a relatively high dose for the initial 3 to 6 days, followed by oral prednisolone started at a maximum of 1 milligram per kg per day and tapered off to the minimum possible doses by the end of induction. And this is followed by IV cyclophosphamide, 6 doses given every 3 to 4 weeks, or MMF, at 600 milligram per meter square twice a day for 6 months. The period of induction is followed by a maintenance, and it is generally acknowledged that MMF is a better agent as compared to azathioprine for maintenance. There is an emphasis of steroid minimization or steroid sparing because of the recognized long-term complications associated with corticosteroid used on the long term. The average time to complete a partial remission in a systematic review of literature was 8 months with a 95% CI of 4 to 12 months. It is important to keep this in mind to understand the timelines of modifying treatment while managing patients with lupus nephritis. Having said that, it is important to reassess patients at 3 to 6 months of induction in order to determine whether they are deteriorating or have not even entered partial remission. And in such refractory disease, the options are to switch between induction agents, so MMF to cyclophosphamide and vice versa, adding on a CNI, or using IV rituximab. So let's look at the evidence base for all of these therapies quickly. So in the last 3 decades ago, a series of NIH trials were done that showed that cytotoxic therapy improved renal survival when compared to high-dose prednisolone alone. But because of the dose of cyclophosphamide and prednisolone used in these trials was so high, there was a high rate of adverse events, including premature ovarian failure and other infectious complications. A series of trials, including the ARMS trial, focused on comparing MMF to high-dose cyclophosphamide subsequently, and it showed the non-inferiority of MMF to high-dose cyclophosphamide with lower rates of adverse events, with almost an equal infectious complication rate. The Eurolupus trial then subsequently showed that the risk of death, end-stage renal disease, or doubling of serum creatinine was much lower was similar with low-dose cyclophosphamide when compared to the high-dose cyclophosphamide. And here the low-dose cyclophosphamide was defined as 500 milligrams given every 2 weeks for 6 doses. The investigators noted that severe infections were much lesser in patients who received the low-dose cyclophosphamide. And at 10 years of follow-up, these primary efficacy endpoints were still similar between the two groups. The original Eurolupus trial was conducted in Caucasians, but since then, a number of trials have used the low-dose cyclophosphamide regimen in large international multi-ethnic cohorts and have shown that complete response rates irrespective of ethnicity is similar. The only difference is in African American population who seem to respond better to MMF. In 2015, a randomized control trial was conducted that examined multi-target therapy, which was a combination of low-dose tacrolimus and low-dose MMF. And the investigators showed that this multi-target therapy was superior to conventional cyclophosphamide at 6 months of follow-up. However, in the extension phase of this trial, at 18 months, there was no benefit of multi-target therapy in reducing kidney flares. And also, there was a higher risk of infections. That is definitely a concern when we use a combination of TAC, MMF, and prednisolone. So while multi-target therapy might be better at inducing remission, this data comes from a series of Chinese trials, so it may not be generalizable to other ethnicities. And because of this high rate of infection, it is prudent to reserve a combination of MMF and CNI to patients who are either refractory or show very severe proteinuria. The Cochrane review also showed that MMF was similar to cyclophosphamide in inducing remission, with a slightly high rate of GI complications. So while the LUNAR trial failed to meet its primary efficacy endpoints, the literature on rituximab use shows a complete or partial response rate of between 70 to 80% outside the context of a clinical trial. And this response rates were satisfactory in patients with both proliferative class 3 and class 4 lupus nephritis, as well as in class 5 lupus nephritis. And therefore, IV rituximab is an agent that is reserved for patients with refractory disease. Another context in which rituximab is worth a mention are these protocols of steroid minimization or withdrawal. So this is the rituximab loop protocol, which includes remission, inducing remission by IV methylprednisolone pulses, high-dose rituximab at 1000 milligram per 1.73 meter square, given at days 1 and 15, along with MMF. The steroids are rapidly tapered off by 3 to 6 months and are completely taken off by a year. And in a publication of a small cohort of 50 pediatric patients using this rituximab protocol showed excellent results at 24 months. The rituximab protocol is widely employed in UK currently at most centers, both in children as well as in adults, and it's shown an excellent response rate irrespective of ethnicity. Recently, there has been a paper from India that showed excellent response to rituximab at 3 years of follow-up in pediatric patients. Studies from adults, which is mostly cohort data, has shown that being steroid-free is definitely achievable in 67% of patients with a satisfactory long-term kidney outcome. In 2020-2021, FDA has approved 3 agents for lupus nephritis and lupus. So belimumab is a monoclonal antibody to B-cell activating factor and was shown to have a positive outcome in the BLISS-LN trial when it was added on to a standard of care therapy with either cyclophosphamide or MMF. The effect size was 11% at 104 weeks of follow-up. Voclosporin is a calcineurin inhibitor, and in the Aurora 1 trial, voclosporin was when added on to MMF and prednisolone, showed a positive outcome with an effect size of 18.5% at 52 weeks of follow-up. Anifrolumab is a type 1 alpha antagonist and has been FDA approved for lupus. So voclosporin is FDA approved in adults with class 3, 4, and 5 lupus nephritis with an eGFR of more than 45. One of the most noteworthy features of the trial protocol was this rapid steroid tapering. So by 16 weeks of therapy, adults were on steroid doses which were as low as 2.5 milligram daily. And this was extremely interesting that despite this, addition of voclosporin to MMF improved outcomes at 52 weeks. The extension of the Aurora 1 voclosporin trial to the next 24 months showed that the eGFR remained stable over the next 3 years and a urine protein creatinine ratio was lower. So this alleviated concerns of long-term CNI use in this population. Obinutuzumab is an anti-CD20 agent, and it is a potent B-cell depleting agent. It causes B-cell ablation not only from the peripheral blood, but also from the tissues. And in this Nobility phase 2 trial, when obinutuzumab was added on to standard therapy, a positive outcome was shown with an effect size of 19% at 52 weeks. An ongoing phase 3 trial, the Regency trial of obinutuzumab, is expected to have results by 2024. So while MMF is equivalent to low-dose cyclophosphamide, practically there may be issues of compliance and GI intolerance. Also, trials are limited in children, and there's lack of long-term data, especially in severe disease. CNI with MMF as a combination is probably better at controlling proteinuria, but a high infection rate should be kept in mind. And obviously, we need more long-term data of CNI-based therapies, especially in children. There is an option of belantamab, but the cost of therapies would be limiting. The KDIGO 2021 guidelines also mention MMF and cyclophosphamide as the standard of care, with an option to consider CNIs and B-cell targeting biologics, an option to consider rituximab when considering steroid minimization. There's overall consensus on maintenance therapies, and it is the MMF is regarded overall superior to azathioprine because of the low rates of kidney flares associated with MMF. Pure membranous lupus nephritis, the evidence base is low, but any of these agents may be used with a 40 to 60% response rate. Can we ever stop all therapy in lupus is a question that is highly debated. And in a recent RCT that attempted prednisolone withdrawal in patients who had quiescent disease for more than 1 year, showed a 4-time risk of flares. So it is suggested that a complete remission for at least 3 years and maintenance for at least 5 years is required before contemplating stopping all therapies. The outcomes of pediatric lupus from a systematic literature review, both patient as well as kidney outcomes, ranges between 80 to 90%. And it is important to understand that lupus is associated with multiple comorbidities affecting multiple organ systems. And infections account for up to 50% of all deaths in lupus nephritis. So it is important to vaccinate these children whenever feasible to prevent vaccine-preventable diseases. On the long term, it is important to recognize kidney flares early by a clinical and biochemical follow-up, and supportive therapy is recommended, including sun protection, blood pressure control, use of hydroxychloroquine and ACE inhibition, calcium and vitamin D supplementation, statins if indicated, vaccination as I mentioned, and also to discuss reproductive health. Annual monitoring of disease damage is recommended, monitoring of antiphospholipid antibodies, vitamin D levels, lipid profile and thyroid profile annually. Eye evaluation, including evaluation of color vision and field of vision, is recommended annually, and bone densitometry is recommended every 2 years. So the goals of management should be holistic care and improvement of long-term care. So while all of my other slides show how to preserve renal function and on the long term, and all of these therapies target prevention of organ damage and prevention of kidney flares, as a clinician, we need to manage the various comorbidities associated with lupus nephritis in an individual patient. It is important to improve treatment adherence, prevent treatment-related toxicity, improve quality of life, including preservation of fertility. It is important to recognize patient-reported outcomes, including anxiety and depression, and emphasize non-pharmacological interventions, including physical activity and provision of psychosocial support. So to summarize, intensive treatment is usually required in young children. While MMF is similar to low-dose cyclophosphamide, the side effect profile, cost, and compliance are needed. We need to keep these in mind to individualize therapy. CNIs may have a role in induction therapy, and multi-target therapy seems promising. There is a focus and emphasis on steroid minimization, and it's important to recognize the long-term complications associated with steroid use. B-cell inhibition may be useful, especially in refractory disease. While newer agents are available, cost and availability are limiting. MMF is better for maintenance, but withdrawal of all immunosuppression is debatable. And the goal should be holistic care, including monitoring for kidney flares and supportive therapy. Thank you.
So we thank Dr. Priyanka Khandelwal for a very comprehensive presentation on the topic, that is management of lupus nephritis. And she has very rightly pointed out the role of kidney biopsy, treatment as per class of the lupus nephritis, and especially the maintenance therapy and treatment of flares after with stoppage of the immunosuppression. So now I request Dr. Lisa Dorman to present her case scenarios. Then we can take up question answer session. And now request Professor Bagasar also that in the session to conduct the question answer session and concluding remarks. Dr. Lisa.
Good evening, sir.
Yeah. Now, thank you very much for accepting our invitation for presentation of case scenarios. You can present the cases and then subsequent discussions shall be taken over by Dr. Bagasar.
Okay, sir. Is my screen visible, sir?
No. Still the screen is not visible. So Dr. Jiten, can you ask, can you help her? Yeah,
I think
Ms. Neha can help her.
Yes, if the screen is hello, am I audible?
Yeah, you are audible.
Yes, ma'am, you can mail me the PPT.
yeah, is it visible now?
No,
Yes.
Yeah, now it is visible. You go ahead, please.
Good evening, everyone. I would like to thank the organizers for giving me this opportunity to be part of this academic program. Today, I'll be discussing the case presentation of lupus nephritis. So coming to case number 1, we have Miss G, a 13-year-old girl. She presented with complaints of fever for the past 9 months and joint pain and swelling for the past 1 month. In the initial presentation, she had a joint pain and swelling which involved the small joints of the hands, elbows, shoulder joints, and neck pain, which was insidious in onset and progressive in nature. It was associated with morning stiffness, which lasted for around 2 to 3 hours. And she also had a maculopapular rash over the lower limbs, which lasted for around 2 to 3 days, 1 month back. This was associated with fever, which was low grade, up to 100 degrees Fahrenheit documented, not associated with chills and rigors for the past 1 month. And she had one episode of vomiting per day, which was non-bilious and non-projectile for the past 1 week. On examination, she was underweight, stunted with a low BMI. The vital parameters were within normal limits. In systemic examination, in a musculoskeletal system examination, she had a swelling of the proximal and the distal interphalangeal joints with bilateral hands and wrist and shoulder joint swelling. She had no organomegaly. Rest of the systemic examinations were within normal limits. Coming to the database, we have a 13-year-old girl. She presented with a progressive joint pain and swelling and morning stiffness for the past 9 months, which was associated with fever. On examination, had swelling of PIP and DIP joints, bilateral hand, wrist, and shoulder joints. So a provisional diagnosis kept at this time was a connective tissue disorder in view of the constitutional symptoms and multiple joint involvements. Coming to the investigation, her initial investigation at presentation showed elevated ESR with a normal hemogram. And during her disease course, the child gradually developed anemia with thrombocytopenia and lymphopenia with an elevated, persistent elevated ESR. In the serum biochemistry parameters, her biochemistry parameters were within normal limits. However, in the urine analysis, she had subnephrotic range proteinuria with isolated pyuria, and the urine cultures were sterile, and there were no RBCs in the urine. In the autoimmune immunological workup, her ANA was positive with a low complement levels. Both C3 and C4 were low, DCT was positive, and anti-dsDNA was positive. Keeping a possibility of lupus, we had planned for kidney biopsy. As discussed by Dr. Priyanka, the indications of renal biopsy is in a patient is suspected lupus with proteinuria 1+ or more, or microscopic hematuria, which is confirmed on 2 occasions 1 week apart, or deranged renal functions. Our patient had a suspected lupus with proteinuria 1+ or more, so we went ahead with the kidney biopsy. The kidney biopsy showed moderate mesangial expansion, and all glomeruli showed thickened basement membrane. Tubules showed mild atrophy, which was accompanied by interstitial fibrosis and mild lymphomononuclear inflammation. And the immunofluorescent microscopy showed a full house pattern suggestive of lupus nephritis class 2. So as discussed, she had a positive ANA for the entry criteria and a score of more than 10, as she had a considerable symptoms of fever, joint involvement, a renal biopsy suggestive of lupus nephritis, low C3, C4, and positive anti-dsDNA antibody. As discussed, coming to the management of lupus nephritis class 2, a patient presenting with non-nephrotic range proteinuria, no steroids are indicated unless for extrarenal manifestations. And if a child presents with nephrotic range proteinuria, we go ahead with oral prednisolone at a dose of 1 mg per kg per day for 4 to 6 weeks, plus MMF or azathioprine. In our index case, when we started the child on prednisolone at 1 mg per kg per day and tablet hydroxychloroquine at the rate of 5 mg per kg per day with sunscreen advice, and the adjunct therapy of enalapril was started for our proteinuria. Coming to case 2, we have a Miss S, who is 11-year-old female. She presented with complaints of progressive swelling of body for the past 2 weeks, frothy urine for the past 2 weeks, and a red-colored urine for 1 week duration. In the history of presenting illness, she developed edema 2 weeks back, which started over the periorbital area and progressively involved the abdomen and lower limbs. It was associated with frothy urine for the past 2 weeks, and in the past 1 week, she had developed a red-colored urine, which was not associated with pain while maturation or fever, vomiting, or loose stools, no history of loss of consciousness or abdominal body movements, and there was no history of oral ulcers, alopecia, or joint pains. In the general physical examination, her enteropermeterally were within normal limits. However, she had a stage 2 hypertension with pallor, edema, and malar rash. In the systemic examination, her abdomen was distended. However, she had no organomegaly. Rest of the systemic examinations were within normal limits. In the database, we have an 11-year-old girl with a generalized progressive body swelling since the past 2 weeks, a frothy urine for 2 weeks, and history of red color urine for the past 1 week. On examination, she had pallor, edema, malar rash, and hypertension. So a provisional diagnosis of nephritic syndrome was kept as the onset was of older age. She had hypertension and had malar rash. So in a child presenting, so coming to the investigation of this child, she had a hemoglobin of 7.1 with elevated ESR. There was no thrombocytopenia or lymphopenia. In the biochemistry profile, she had deranged renal functions with hypoalbuminemia. Urine examination showed hematuria, RBCs of 194 per high power fill with nephrotic range proteinuria, and her coagulation profiles were within normal limits. In the autoimmune workup, her ANA was positive, 4+ homogeneous in pattern, with both the complement levels C3 and C4 low with anti-dsDNA positive. Her DCT and APLA workup were negative. Coming to the differential diagnosis of a child presenting with hematuria and proteinuria, the primary renal disorders which we usually see are focal segmental glomerulonephritis, membranoproliferative GN, or an IgA nephropathy. And in the secondary causes, the commoner causes are systemic lupus erythematosus, Henox cornein purpura, infections, or malignancies. In this child, we went ahead with the kidney biopsy, and the kidney biopsy showed a lobular accentuation with mesangial matrix expansion and hypercellularity, endocapillary hypercellularity, and keratoctic debris with the basement membrane thickening. And the immunofluorescent microscopy showed a full house pattern with an activity score of 6/24. suggestive of lupus nephritis class 4+5. And as suggested in this, the child had ANA positivity with low C3C4, anti-dsDNA positivity, and a renal biopsy such as lupus nephritis, which confirmed the diagnosis of lupus. As discussed by Dr. Priyanka, in the management of class 3 and 4, it is divided into two phases. That is the induction phase and the maintenance phase. The induction therapy, it aims to control the disease activity by inducing the remission of disease flare, and the maintenance therapy aims to avoid the relapses and control disease by limiting inflammation and damage. So for the induction phase, we start with IV methylprednisolone at a dose of 30 mg per kg, maximum dose of 1 gram for 3 to 6 days, followed by oral steroids. And either we can give IV cyclophosphamide or MMF, which have been already described. And once the child goes into remission, we taper the oral steroids, and the maintenance is the MMF is preferred. In our index child, for lupus nephritis class 4, for the lupus nephritis, we went ahead with pulse methylprednisolone at a dose of 30 mg per kg for 5 days, followed by pulse cyclophosphamide at 500 mg per meter square, and we started oral steroids at 1 mg per kg. For the AKI, we continued with the supportive care. The child required multiple antihypertensive medications for stage 2 hypertension, and we started on adjunct therapy of hydroxychloroquine at 5 mg per kg per day with calcium, vitamin D, and sunscreen application for the child. On follow-up at 4 weeks, she came for her second pulse of second pulse cyclophosphamide. In this time, the hematuria had resolved and the rash had resolved. However, the child still had nephrotic range proteinuria, and the AKI had improved, and the hypertension was controlled with enalapril and amlodipine. So SLE is a chronic disease with possibility of frequent renal flares. Hence, the children needs to be followed up regularly and monitored. So for monitoring on follow-up, blood pressure and height evaluation is important. And for the assessment of remission status, we should look for urine examination for the active urinary sediments and spot urine protein creatinine ratio, and renal function tests. C3C4 and anti-dsDNA levels should be monitored regularly. And eye evaluation at baseline and every yearly should be done for the toxicity of hydroxychloroquine. And compliance can be a major issue, and it needs to be addressed during each clinic visit. Adjunct therapy in patients with lupus nephritis is advised as per the 2019 update. A RAS blockade is recommended, and vaccination against influenza and streptococcus pneumonia is strongly recommended. And statin therapy should be considered on the basis of the lipid levels in the child with nephrotic syndrome. And bone protection and prevention of osteoporosis must be done in these children. Coming to the case scenario 3, we have an 8-year-old female child who presented with complaints of fever for the past 9 months, multiple joint pain and swelling, and progressive abdominal distension for the past 9 months, and headache for the past 3 months. In the history of presenting illness, the parents noticed that the child was not gaining height at 5 years of age, for which they had consulted a private practitioner. And in the meantime, in the last 9 months, she developed pain over the right knee, followed by left knee and both ankles. And this was associated with fever, which was undocumented, and initially was relieving with medication. And this fever was associated with history of oral ulcers, photosensitivity, and palpitations. During this period, the child also developed anasarca, progressively abdominal distension, and it progressed to involve the whole body. For this edema part, the child was evaluated in a private hospital, and she was found to have increased TSH levels, for which levothyroxine was started by a private practitioner. And during this period of past 3 months, she developed headache, which was non-specific in nature, and it was not associated with any vomiting or loss of consciousness or any abnormal body movements. And for this complaint, she was referred to our center. So in general physical examination, she was wasted and stunted. She had tachycardia, and on examination had pallor and bipedal edema. In the systemic examination, she had a hepatosplenomegaly. Liver was palpable 7 centimeter below a causal margin with a spleen of 4 centimeter, and a shifting dullness was present. The rest of the systemic examinations were within normal limits. So in the database, we have an 8-year-old girl with a chronic febrile illness, history of polyarthritis, oral ulcers, photosensitivity with headache and anasarca. And on examination, she had pallor, wasting and stunting, bipedal edema, ascites, and hepatosplenomegaly. So the possibilities kept in this child in view of the systemic involvement was as the child had a fever for the past 9 months with hepatosplenomegaly, joint pains. So a autoimmune disorder such as lupus or chronic infection was kept as a possibility in this child. So we went ahead with the investigations, and the investigation initial admission showed anemia of 8.5 with elevated ESR of 61. There was no thrombocytopenia or lymphopenia. She had a normal renal functions and however had hypoalbuminemia and elevated CRP at the admission. In urine examination, she had RBCs of 10 per high powerful and nephrotic range proteinuria. Her coagulation profile were within normal limits. In the immunodeficiency workup, the rest of the workup was normal. And in the autoimmune workup, her ANA was 4+ homogeneous positive, and she had low complement levels C3 and C4. Anti-dsDNA was positive. DCT and APLA workup were negative. In view of the elevated TSH done outside, we had repeated the thyroid profile, which showed increased TSH, and anti-TPO was positive. We went ahead with the kidney biopsy. Her kidney biopsy showed endocapillary proliferation and no crescents or fibrillar necrosis or viable lesions were seen. Immunofluorescent microscopy showed a full house pattern with an activity index of 1/24, and impression cap was lupus nephritis class 3+4. So in this child, she had a positive ANA with constitutional symptoms of fever, oral ulcers, joint involvement, renal biopsy suggestive of lupus nephritis with low C3, C4, and a positive anti-dsDNA antibody. In view of the systemic illness, presence of systemic illness and fever, hepatosplenomegaly, joint pains, and evidence of lupus nephritis, a possibility of monogenic lupus was kept in this child, and a workup was done. So in the X-ray spine, the child had a plateau spondyly and lacunar lesions localized to the posterior third of vertebra, suggestive of a SPENST, that is spondyloenchondrodysplasia. And NCCT had showed bilateral basal ganglial calcification. We went ahead with the genetic analysis, and her genetic analysis showed homozygous pathogenic mutation in the ACP5 gene. So in the treatment of this child for lupus nephritis, she was started with methylprednisolone pulse at 30 mg per kg per day for 5 days, followed by oral steroids at 1 mg per kg per day and MMF at 600 mg per meter squared BD doses. And she was discharged on oral steroids, MMF, hydroxychloroquine, thyroxine, sunscreen, and calcium and vitamin D supplementation. On follow-up, she is currently on MMF and low-dose steroids in complete remission, and her fever and anasarca is now passive with improvement in the hepatosplenomegaly. However, there is no improvement in height in this child. A short word about spondyloachondrodysplasia. SPENST is associated with platyspondyly growth retardation and enchondromatosis. The ACP gene encodes the tartrate-resistant acid phosphatase associated with immune osseous disease. So various immunological findings have been reported, including typical SLE with malar rash in children with SPENST, lupus nephritis, normally class 3 and 4 lupus nephritis has been reported in these children, and with antiphospholipid syndrome, Sjogren's, vitiligo, myositis, Raynaud's, ANA, and anti-dsDNA positivity has also been reported in children with spondyloachondrodysplasia. So in summary, we should think of our secondary causes whenever atypical features of nephrotic syndrome are present. Lupus is an important cause of nephrotic syndrome in children. The lab clues that we get in the children with lupus is that the child will have a low complement levels, ANA positivity, and anti-dsDNA positivity. And in class 3 and 4 lupus nephritis, aggressive early treatment is warranted. And if a child presents with an early onset lupus or a familial lupus or syndromic lupus, a monogenic lupus possibility should be kept in mind. Thank you.
So thank you, Dr. Isa, for your interesting case scenarios, having all the 3 clinical patterns and a serological marker. And in all the 3 cases, you have followed the standard protocol for remission induction and then maintenance therapy. So now I hand over the platform to Professor Bagga sir to conduct the further any question answer session. Dr. Bagga sir.
Thank you, Priyanka, and thank you, Lisa, for excellent presentations on a topic, that's obviously rather heterogeneous, but nevertheless, important to know. So Lisa, there's a question in the chat box that do you really need to follow the EULAR criteria for diagnosing lupus?
So the recent 2019 guidelines have, the only thing is that the entry criterion is ANA positivity. So sometimes at the first presentation, the child might not have an ANA positivity. So repeat ANA testing should be done repeatedly if we have high risk of suspicion, if we have high index of suspicion of lupus nephritis, and we should follow the EULAR criteria.
Priyanka, do you have anything to say on this?
So the EULAR criteria, which is the most recent criteria, is different from the SLIC criteria because it is more sensitive and less specific. The SLIC criteria was more specific, and both SLIC and EULAR criteria are classification criteria rather than diagnostic criteria. And for any classification criteria, I think while we are using them for diagnosis, but still for an individual patient, we should consider them case by case. And if a patient does not meet the complete EULAR criteria, it's very rare for them to have SLE, but it is definitely possible.
Okay, thank you. Thanks. Thank you, Priyanka. Priyanka, so the indications for kidney biopsy, could you just enunciate them once more, for the audience? Just because there was a question that does
Yeah.
1 proteinuria get counted as an indication always, or would you ignore a 1+, or would you rather always try to quantitate, rather than just relying on 1+ proteinuria?
So actually, the issue here is that guidelines, KDIGO guidelines and all guidelines are all adult guidelines. And here the cutoffs for proteinuria are very much higher than what is emphasized by pediatric nephrologists as a whole. So this is not based on guidelines. So, but the UPUC ratio of more than 0.2, because that is the cutoff that's actually taken for complete remission in children. So anything beyond that cutoff is probably an indication for a kidney biopsy. And it is always, I think it's always better to quantify the proteinuria rather than relying on dipsticks. Of course, a dipstick of 3+ 4+ is that's clearly an indication, but anything 1+ to 2+ should probably be quantified. That's for proteinuria. The other thing is deranged renal functions. So obviously that is an indication. And the third thing, which may or may not, although we have written in our protocol that presence of casts or RBCs, which are microscopic hematuria, which is persistent on more than 2 occasions, should also be an indication to biopsy. The idea is not to miss lupus nephritis in these patients because the therapy would then be defined by the presence or absence of lupus nephritis.
Okay, good. So Priyanka, again, there's another question, that in case you have in a child who has lupus nephritis class 4, but she's 13 years old, are there any risks of giving IV endoxin over MMF? And suppose you really have to choose one, what would you choose?
So I think the long-term data of IV endoxin in this, so because it all depends, the previous trials had used very high dose IV cytotoxic therapy, and therefore the risk of impaired fertility later on was definitely there. But I'm not very sure on the evidence base for low dose cyclophosphamide on the long term for impairing fertility as a whole. So I think as a one-to-one discussion with parents should be done, and their views should also be considered, because MMF and cyclophosphamide are, as it is, they are equivalent in all trials and meta-analysis, given, their efficacy is equivalent. So either of these therapies can be chosen.
So another question on cyclophosphamide, so you did say that it would take about 4 to 6 months or maybe a bit longer for for remission to be induced. So at what time do you start getting worried? Do you start getting worried at 3 months, or say somebody continues to have nephrotic range proteinuria even at 4 months? Are you worried, or would you just wait on for 6 months?
So there are some adult data which suggests that not even partial remission by 3 months, or deranged renal functions, or not even achieving partial remission by 3 months. In such patients, the probability of attaining complete remission by a year is lower as compared to patients who had attained partial remission by 3 months. So I think the one assessment at 3 months is definitely required. And if the patient has not even attained partial remission, is persistent to have nephrotic range proteinuria, would probably merit an earlier intervention than later on.
And that intervention, the first step, as you said, would just mean or substitution of the other drug, or would you think about something else?
Yes, sir.
Yes, sorry, just carry on. Yeah.
So actually, there are if there is persistent nephrotic range proteinuria, there is enough data to suggest that addition of a CNI would be beneficial, because they are more efficacious in controlling severe nephrotic range proteinuria. So probably addition of a CNI would be beneficial rather than switching induction agents if a patient is actually having severe nephrotic range proteinuria at that point in time. So that is one option. The other options, obviously, for refractory disease is switching between induction agents and considering of rituximab, which can be also considered later. And now the newer KDIGO guidelines give the option of voclosporin and belimumab, both of which require more data in children.
So would you suggest, that if somebody does not do well on IV cyclophosphamide or an MMF, rather than switching, one should consider the use of CNI earlier, compared to switching? That's what you seem to be saying. Yeah. Would there be any indication to begin with rituximab? There's a question in the chat box as well. Would you ever have an indication to begin with rituximab? You did mention a trial.
I did mention
it was being used a lot in the UK.
In UK, yes. So presently in UK, the protocol they are following is IV methylprednisolone along with MMF at a standard dose, and along with the use of rituximab, 1000 milligrams per meter square at day 1 and day 15. And that they are doing with an intent to take off prednisolone by 3 to 6 months. And in some patients even earlier. And they are doing this in a number of centers, both in adults as well as in pediatric patients. And in adults, they are yet to publish this. They haven't yet published, but there's no difference between ethnicities or any other factor that influences the efficacy to induce complete remission and maintain it by using this protocol. So this is a completely different protocol. It's not mentioned in any of the guidelines as of now. KDIGO does mention the use of rituximab if you are considering steroid withdrawal. But as of now, the standard therapies where data is available is either endoxin or MMF.
So Dr. Priyanka, sir.
Yes, sure.
Yeah. Dr. Priyanka, it means that if proteinuria, there is no partial remission, nephrotic range proteinuria is persisting at 3 months, that is 3 pulses of cyclophosphamide, then we should stop cyclophosphamide and switch over to either 2 doses of rituximab or this one, tacrolimus. And subsequent pulses of cyclophosphamide should not be given. This is the inference?
So if you are labeling as refractory, again, when the label of refractory disease is given is another debate, but probably between 3 to 6 months. If proteinuria is continuing at 3 months, then probably an addition of CNIs would be beneficial in patients with severe nephrotic range proteinuria. And thereafter, despite all this, if the patient has not attained remission, even partial remission, is persistent to have refractory disease by 6 months, then probably switching between induction agents or addition of rituximab should be considered.
So between 3 to 6 months, we will give triple immunosuppression, prednisolone, and tacrolimus and pulses of cyclophosphamide. My question is that we should switch up the cyclophosphamide. We consider tacrolimus and this one, prednisolone.
So actually, whatever data for CNIs is available with MMF. So
With MMF, yeah.
Yes, sir. So low dose MMF, not even high dose.
600
Low dose
milligram you
MMF
told.
with CNI. Yes, sir. And along with prednisolone. So that is the data which is
Prednisolone,
available.
low dose alternate day, na? Maybe 10 to 15 milligram, as you said. By that time, prednisolone should be an alternate day between 3 to 6 months.
Yes, sir. And then and then tapered to the minimum possible doses by 6 months.
Yeah.
Yes, sir.
Okay. Please carry answer.
Okay, so Lisa, can you tell us some differences of lupus nephritis in boys versus girls? Are there any differences, or they're almost similar disease, Lisa?
So in the incidence of lupus nephritis in pediatric children is more in females than in males, and so the disease severity,
yeah, the manifestations, serology, are they different? Are they, and the outcomes are different, or are they similar?
So the manifestations are in the manifestations of the renal manifestations are more in the females, and I think the outcome is more in the outcome difference is similar only, sir.
Priyanka, do you want to add something to this?
So I think the only thing is that the severity in some studies, it says that boys have a much more severe disease than girls, but I don't think so there's much difference in the outcome.
Okay.
Yes.
Okay. Lisa, another question for you. Can serum albumin be used as a surrogate for remission? When you are, rather than if you can't do a UPUC, can you use serum albumin as a surrogate marker?
So as per the guidelines, we have to look for the improvement in proteinuria, and as well as the absence of the active urinary sediments and improvement in renal functions. So I think using serum albumin as a surrogate marker will be a bit difficult to monitor in a child who we have to monitor lupus nephritis every 3 to 6 monthly if a child comes to us.
Yes, you're right. So I think serum albumin would be a rather gross parameter, you know.
Yes, sir.
One is looking at a much more subtle kind of one can't use the word subtle, you know, but a less gross thing. So perhaps a urinary protein to creatinine may be better. Is that okay? Is that okay, Priyanka? So one would not use serum albumin as a surrogate for remission.
Yes, sir. Definitely, sir.
Okay. One question again, Lisa, to you. Does one modify the initial dose of cyclophosphamide in patients with significantly deranged kidney functions?
Yes, sir. We have to modify the dose of cyclophosphamide. If the eGFR is less than 50%, then we have to modify the dose.
Yeah. And a corollary to this, you know, would there be any indications of plasma exchange in lupus, Priyanka?
So I think the indications would be one is TMAs, but then the evidence is again not. There's no real trials, or it's just anecdotal evidence. That's the only thing that I can think of.
So clearly the evidence for plasma exchange is not very great, you know. Yeah. There's
Unless it's TTP and in adults,
yeah.
those kind of
Yeah. There's another question, you know, the causes of recurrent pleural effusion in a boy with class 4 lupus. TB workup was negative and disease activity was negative. Okay, that's odd. Yeah. Priyanka, recurrent pleural effusions in a boy with lupus class 4 with no disease activity. It's a bit odd to explain, you know. Mm-hmm.
Very difficult, sir.
क्या हो सकता है मतलब infection सोचोगे But obviously one would do a pleural tap first, to see the kind of pleural
to see
diffusion.
this, sir. Whether it's transudative, exudative, tubercular etiology should be, because we
Then,
keep these children on
then
immunosuppression.
maybe we'll have to kind of think about, because I would imagine that one can get pleural effusions with active lupus. And Priyanka, would you like to say something on this?
It's very odd. I mean, yes, so you're absolutely right. So pleural tap would be required to at least see what kind of fluid it is and then go from there.
Yeah. Priyanka, when would you do a repeat kidney biopsy in a patient with lupus nephritis? Would you do it in every renal flare, or would you wait for, so how would you manage a renal flare?
So I think the classical classification is again mild, moderate, and severe flare. Severe renal flare would be deranged renal functions or the presence of nephrotic range proteinuria. Minimal flare would be just some proteinuria and some RBCs or casts without having too much of proteinuria, and moderate is somewhere in between. So in severe renal flares, obviously, because we would require a biopsy to figure out whether there has been a class switch, and also to prognosticate the patient in case we are thinking this in terms of how much chronicity there is. So for severe flares, definitely when we are considering modification of significant therapies in an individual patient, then we would consider.
But again, practically speaking, correct me if I'm kind of wrong, that one would obviously, if you think clearly that there is a flare, one would at least go up on daily corticosteroids, perhaps.
Yes, sir. Yes, sir.
And get the child better, and then take a call, Finally, you end up doing, in most cases, yeah, I would imagine.
Yes, sir. Yes,
sir. Dr. Mishra, any other comments?
Yes.
I don't think we have taken all the questions.
They have answered most of the questions, sir. One of my sir, recently I had a child, 13 years old, male child, with phenotypic appearance is henoxalin purpura, classical palpable purpura over the buttocks, lower legs, abdominal, colicky abdominal pain, melena, and hematuria. But when we investigated and found that one investigation outside was already done, there was low C3, C4, ANA, and anti-dsDNA positive. I repeated from another lab, and same was still positive. Then we did the biopsy, and it was class 3 lupus. We started methylprednisolone, 3 pulses, followed by oral prednisolone, and I think the third dose of cyclophosphamide is due in first week of June. Gradually, the proteinuria is coming down. So my concern is that I could not find in the literature except one case report that HSP phenotypically and serologically lupus nephritis positive.
Yeah.
Extremely unusual situation, and but we are treating like class 3 lupus nephritis.
Fortunately, the treatment is easy. Diagnosis at times is more difficult, but the treatment perhaps is usually perhaps similar. Yeah.
I couldn't find in literature, sir. Only one case report was there, that HSP with lupus nephritis, but it's very rare. From a distance, several pediatricians has seen in the city henoxalin purpura. One has investigated serological marker. We had a doubt whether it is positive or not. We again repeated from a lab, and same titer was there, sir.
What were the features of henoxalin?
Henoxalins are bilateral lower limbs, palpable purpura, mainly extensor aspects, dorsum of the hands, severe colicky abdominal pain, hematuria, proteinuria. These were the features, sir.
Yeah, but one should remember, that about 10% of lupus may have a small vessel vasculitis.
Yeah.
And we had a similar child, a few days back.
Yes.
And my colleagues in the unit would know, that who had presented with a rash that was like a small vessel vasculitis and with systemic lupus. So do remember, that about 10% or maybe a bit lower figure with lupus may have a small vessel vasculitis.
Yes.
So it may not be as classic as henoxalin.
Yes, sir.
Yeah, कभी-कभी हो सकता है।
और सर मेरे को ये लगा ना, वो आया तो मेरी भी क्लिनिकल डायग्नोसिस हेनोस्टोन पर हो रही था। और यूनिट डाउट किया कि नहीं, ये सीरोलॉजिकल रिपोर्ट गलत हम कर नहीं, इसको दूसरे लैब से, रिलायबल लैब से कराते हैं। फिर पॉजिटिव आया, देन वी डिड द बायोप्सी सर, एंड नाउ वी आर मैनेजिंग लाइक लूपस। बट बड़ा रेयर है सर, बिल्कुल। उसको एब्डोमिनल पेन भी था, मेलिना भी था सर, बट
Dr.
Same
Srinivas
thing,
says
sir.
one should look at ANCA vasculitis as
Yeah.
well. You know, 10% can have ANCA positivity and necrotizing. Yeah.
Yeah.
Srinivas, thank you. Thank you. So,
Thank you,
maybe
sir.
you can start the post test, Jitendra. Thank you so much. To both
Thank you,
the